Good morning, everyone. Thanks for joining us today. For everyone who doesn't know me, I'm Surya Ahmed, and I'm one of the PGY5 EMIMs. So 5 years feels like a really long time. Feels like longer than 5 years, but in a good way. And for my senior lecture, I thought a lot about what I wanted to do for it. And I was thinking, is there any one thing that can tie everything together? And really no, but for me, this was the closest thing. I thought about what a good shift felt like and how I felt after my day in the ED. And I realized a lot of times how I felt after really was impacted by how communication went on that shift. And whether that was with patients, colleagues, or nurses or anyone. And I realized when there was communication breakdown, how that could make a shift and completely change the way your day went. Yeah, so overall, so you guys got this in your email about probably Monday. And it was just to get us thinking kind of how we feel as communicators. Overall, we all communicate differently. We're all coming from a different place when we start. So self-perceived scales really are not shown to be valid indicators of our performance communicating. But what is interesting is they are valid a lot of times in how we do perceive ourselves to communicate, and how we perceive ourselves communicating really does reflect a lot of our communication choices, and that can be important. And just to kind of give a little bit of a backstory on why I'm interested in this topic, I've done improv since college, just on my own for fun, and started in Atlanta, in Midtown Atlanta. Just took some classes, and for a long, long time, I actually kept my improv world separate from my medical world. And I didn't really, even in medical school, when I performed with my improv troupe, I didn't really invite a lot of people from med school there. And I felt like I had to keep it separate. But going through med school, I realized even interacting with standardized patients and a lot of the skills they taught us, and then realizing what I was doing and with my improv troupe, I noticed a lot of parallels, and this was really striking to me. And then when I heard about the Alan Alda Center for Communicating Science at Stony Brook, and that they were doing a 2-day workshop for healthcare professionals and scientists, I was so excited that, other people were also that it was important, and other people thought it was important. And I was really, really happy to be able to take this course. And improv doesn't work for everyone, and it's a very personal thing, but I've seen that how awesome it is to kind of connect and realize that it helped me work on communication. So just an overview of today. Overall, higher communication competence really does correlate with higher patient satisfaction and even lower physician burnout. And then lower lapses in communication in the workplace can lead to professionalism issues, among many other things. And then in the ED, a lot of different populations present unique communication challenges for us. And that includes older patients, patients with dementia. And then just at the end, we're just going to touch on a little bit about maybe how we can improve communication using improv. So overall, when we think about any given shift that we have, we can break the groups of people we communicate with up into these 3 main groups. That's us communicating with other physicians in other departments, communicating with other colleagues on shift, and then or nurses or anyone in the ED, and then also communicating with patients and families. And we're going to spend most of the time today talking about communicating with patients. And we might find that although we have a strength in one area, another area might be more challenging. And so it's just kind of interesting to think about it all together. So some of the history, just in general, we know communication is important, but just to give some raw numbers, the Joint Commission performed a study to find root causes for all reported Sentinel events between 1995 and 2005. And the findings actually indicated that poor communication was the most common cause of negative events and serious safety events in the United States, about 68%. Meanwhile, only about 20% was attributed to lack of technical competence. So that's pretty interesting. I mean, we all know it's important, but just to kind of think about it in numbers is also pretty interesting. And so in Boston at Mass General, they designed a communication curriculum for all the ED clinical staff. And before they did the curriculum, they surveyed everyone. And beforehand, 72% thought that it was going to be important. But then afterwards, after they went through everything, 97%. So almost everyone felt that it had helped them in some way. So yeah, just to break it down, like ED staff and other departments, that's, when we deal with conversations with difficult consultants, and even IPASS is one method that has been employed to kind of help with handoffs and decreasing, hopefully to, decrease safety issues when we're handing off from one department to another. And then, when we have our sign outs on rounds, that's another place for communication to break down and communicating in the ED with orders and other things. And overall, then thinking about communicating with populations like patients with mental illness or combative patients in the ED or patients with Alzheimer's disease. And then remembering sometimes although this talk is on communication, sometimes we have to remember our patients will not be able to communicate with us. And that's its own unique challenge. And sometimes, this does come up with older patients when we have to speak with the caregivers, the families, and even in pediatrics, we're talking to the families. I found some research really interesting so language barriers present its own unique array of issues in itself. But one study was a retrospective 9-year study. It looked at intubations of trauma patients, and it actually found that language and communication barriers led to preventable intubations in trauma patients, which I found really interesting. So overall, I feel like COVID really grounded us and reminded us of the basics. And at the end of the day, when medically there was nothing else for us to do, we still had something we could control, and that was how we could communicate with our patients, how we made the families feel, and how we made everyone feel. And at the end of the day, communication is something we can control. In an ED with uncontrollable factors, that's something that we can always hold on to and realize that we have control over. Overall, it's also interesting to look at how we are affected by our communication with patients. So looking at physician burnout and patient experience as really flip sides of the same coin, and realizing how important it might be to make patient experience an imperative. It's going to affect us as well on the other side of that. So overall, I feel like when we do go through, all of our training in med school, it's expected, everyone feels like probably for us to have mastered communication, should be able to do the XYZs of it, but we don't really break it down as much later. But I think it's kind of important to look at, and ADED is a communication framework that we can just always kind of go back to and think, are we doing this interacting with any patient? So it can be, just going into a room. Are we acknowledging, greeting the patient by name, making eye contact, smiling, and also acknowledging the other family in the room too. So not just the patient, realizing that everyone's there, figuring out who everyone is and talking to all of them. And introduce yourself by name, your professional certification, let them know who you are. Don't be, be transparent. And then thinking about, we all know this stuff. A lot of people already do this stuff, but it's just kind of nice to think, are we giving them a transparent estimate of how much time, are we going to have in the ED? We don't know sometimes, so just tell them. We're not always going to know how long they're going to be there. And, explaining step by step what to expect, answering questions, and then thanking them at the end when you walk out of the room. So a lot of just the ED itself, we all know this, a lot of challenges specifically that prevent unique barriers to communication, just the volume, the space, and a lot of things. And that makes it uniquely difficult when we're communicating with older patients specifically. So some of the barriers with older patients that just uniquely inherent to communicating are their hearing impairment, just cognitive impairments, and then dexterity. So EDs themselves almost pose somewhat of a treacherous environment at baseline for older patients. And it's just remembering how we can keep them safe while they're there, and what we can do to improve their experience while they're in the ED. And even if geriatrics isn't your particular interest area, it's kind of important to think about, we're always going to be communicating with older patients, especially in the coming years. It's going to be our reality. And thinking about even in pediatrics, sometimes the caregiver is going to be a grandmother, a great grandmother. Sometimes that's all the child has, and we're going to be communicating with them even in that kind of setting. So it's just really important to kind of think about. So just given that, you know, we already kind of laid the framework for how it's difficult to communicate, but I'm going to give a few different communication tips that we can maybe use for older patients to kind of maybe improve their experience in the ED. And all of these things are going to seem like really straightforward. Like, I already know this, I do this all the time. Like, people may be thinking that, but it's kind of, I just wanted to kind of like, you know, zero in on these and just think about it again and give it some time. So overall, when we walk into a room in the ED, we're going to be distracted. But when we walk in, if we spend the first 60 seconds giving a patient their our undivided attention, it can actually seem like we're giving them more time. And it's really not about pretending we're giving more time. It's just really trying to utilize the time we have, the limited time we have, in the best way possible, and being fully present in the moment with that patient. And if you have time, if there is a seat, take a seat, use that 60 seconds. If you only have 60 seconds, to maybe sit during that interaction. And then maintaining eye contact if possible, and even other nonverbal forms of communication like hand gestures if possible. Like, it's not going to work for everyone, but sometimes it's natural. Sometimes that will enhance a feeling of connectedness with the patient. Even the way we breathe can come across in a certain way. Even, you know, matching a patient's tone of voice or even matching their body language can kind of create a sense of trust between the provider and the patient. And these are things that, you know, they're not like, it's not meant to be mechanical to think about it, just kind of to do it if it naturally happens. And then listening. So this is something that I am also guilty of, just listening to respond rather than to understand. So if we can try to just give them time to tell us their story. So a lot of the time, I mean, I feel like when I do have a older patient that I feel does have capacity, is ANO times 3, they can really tell us everything we need to know. A lot of times I can get the full story from them, and then I know why they're there, and they can really tell us how they're feeling. And sometimes they came to the ED because they're scared they live alone. And sometimes it is all about that, and sometimes it's not. Sometimes they're really sick. But if we listen to them, we might be able to pick up on subtle things. And you know, if they can speak to us. And now there are cases, like I mentioned, like, we know you're going to have an older patient that comes in, they're not going to be able to speak. And then, of course, sometimes when you leave the room, you're going to think immediately, I need to find the caretaker. I need to get the history because I don't know anything right now. And that's going to happen too. But if they can talk and they can understand, it's really important to kind of try to listen, to get the story. And then speaking slowly, clearly, loudly, and even using a deeper tone of voice has been shown to possibly help with communication in older patients. Using just short, simple words and sentences, and then being specific. So abstract thinking kind of be challenging to older patients. So it's kind of nice just to be simple, direct, and speak in short sentences and stick to one topic. And then if we can, simplify and write down the instructions. The caregiver will often be there too, but it's nice to kind of close the loop and discuss everything together. If we can, draw it out, you know, maybe show them in pictures. And then at the end, summarizing the most important points that you can. And overall, it's kind of, you know, and at the end, just give time for questions. A lot of these tips, even though I was speaking directly about older patients, these can be used for any patient interaction, really. Just kind of thinking about good communication tips in general. And so now I'm just going to talk about a couple studies. I didn't like the title of this study, to be honest, but it kind of evoked, it seems like it invokes like a emotional response. But it really, so I liked the way it was set up. So it's a study out of Manchester, UK in 2019, and it studied what, from the point of view of a patient with dementia, what did they find meaningful about the interaction? So it was a qualitative study, and it was short video interviews between a patient with dementia and their caregiver. And they interviewed these, they videotaped interactions between patients with dementia and their caregiver. And then they later, when they recruited these patients who had capacity, they would play back the videos for these patients. And they asked them, they stopped at every 1 or 2 minutes, and they said, what did you find meaningful about this interaction? And this was kind of an interesting study because it went from studying, like doing research on patients with dementia to doing research with them. And that was important because it actually uncovered that they have an awareness of their relationships and communication and preferences. And even though it may not seem like it, they really did know what was going on, and they could tell subtle changes in the way communication was done. And this was, the authors actually took from the feedback that they got from all the patients, and they summarized in the main themes. And they broke it down to basically shared moments of emotional connection, whether that was through reminiscing on memories or through shared laughter, and then empowering their ability to communicate. So ensuring mutual understanding and connection, trying to enforce emotional and physical presence, and then familiarity is also trying to, like, basically the caregivers, they enjoyed the familiarity and the connection. And then inhibitors to communication were when they felt inferior in conversation, or if they felt they were just being appeased by the caregiver and not really given the time of day. So overall, looking at it in a pictorial model, we can focus on the pragmatic aspects of communication that we kind of broke down, the simple things you can do, but then it's also thinking about the other things, the more abstract things like empathy and compassion that this article kind of brings up, that things that you can't really define, but that patients can really pick up on. And then at the end of the day, what are we really trying to do? I feel like if we create a therapeutic alliance with our patient and try to develop trust, that really sets the stage for the whole patient interaction and can really improve. And at the end of the day, we can be the best doctor we can be, but if we didn't communicate well with the patient, sometimes, it's important, but that's really also important. I actually wanted to show you guys a TED-Med talk that I found really awesome. Two improvisers, Karen Stubble and Monday Carter, have family members with dementia. And they actually, through all their years of doing improv, they realized taking care of their parents, they realized all the similarities they found in what they were doing and what they were doing on stage. And this was based on their experience. So I just wanted to play a really quick clip.
Say yes and.
Agree, don't deny.
Accept offers and gifts.
Be specific.
Listen fully.
Accept the reality given to you.
Go with the flow.
Share focus. Give and take.
Silence can be powerful.
Commit 100%.
Be in the moment.
Those are some of the guidelines for performing improvisation.
Those also happen to be some of the guidelines for being with a person who is living with Alzheimer's. Say yes and. Sometimes it's incredibly hard to accept and jump into the world of a person with Alzheimer's. Accepting their reality means letting go of ours.
So I feel like she really broke it down well in this last clip, because a lot of times we as providers may feel uncomfortable when we don't know what to do or say, when we know for a fact they're not making sense. We know that it's probably going to feel uncomfortable to, agree, to kind of jump into their reality. But at the end of the day, we're not going to change the way they're thinking. There's no way that's possible. But it's not about lying. It's just about being present with them and maybe saying, tell me more about that, rather than writing them off, and just doing what we can. And then at the end of the day in the ED, how this is applicable, we can maybe diffuse some difficult patient interactions. So in general,
sometimes.
Sorry. So overall, so if we think about it and trying it out ourselves in the ED, if we're faced with an interaction, for instance, let's say we have an 80-year-old older patient that they've been resting in the bed for a long time, and we're doing a syncope workup on them. We think it's vasovagal syncope, but we're waiting on a troponin. The chemistry lab is taking 2 hours because it's down. And then, we see them get up out of bed and they're getting agitated, and the nurse is yelling at us, we have to give Haldol, like and our first instinct is it's just like when someone yells, patient is seizing. Everyone wants to solve the problem right this minute. And, eventually probably we may end up giving Haldol, we may end up giving olanzapine, but in that moment, what can we do? Just take a moment to breathe, accepting the reality of the situation, try and at least give it a chance, talk to the patient, don't argue, and just try to go with the flow, letting go of our ego. And overall, this can actually be used for any patient interaction or difficult interaction with anyone in the ED or with anyone in general. So this is just kind of a thing that we can take with us. And I really thought this was cool because there's been a lot of like research on just humor in older patients in nursing homes, and then like people coming to nursing homes and exposing like older patients to humor. But this was cool because it showed that improv and having older patients take improv classes actually improved their sense of connectedness and actually made them feel less lonely and decrease depression. And it's interesting because improv doesn't require memorization. So in an older, if there are barriers in older patients to memory, they could really just jump in and it showed that they had a really good time and it helped them and decrease depression. So in summary, communication is important. Communicating with older patients and patients with dementia can be challenging. Improv may help, but that's not necessarily the point of this talk. It's more so to focus on how we can just think about a situation differently, potentially. And now, how much time do we have? A few minutes? Okay. I was going to quickly go through like some of my time at Kings County. This was the very first picture I took or someone took of me when I was sleeping during orientation. On the lawn, I had no idea what was coming next. And this is probably me on my first inpatient medicine rotation at Downstate. I had no idea the system, didn't know what to do, but eventually learned the system. This is one of my favorite quotes from one of my mentors, Dr. Gardensheimer. Everyone makes mistakes. I make mistakes, but if you try to do the right thing and you learn from your mistakes, I think that really helps make things better. And I really like this quote. These are some of my other favorite quotes. This on the right, pressure is a privilege, was at the People's Improv Theater when my troupe and I were doing an improv show, and it reminded me of our jobs in the ED and how we come in every day, and it's really a privilege to be able to take care of critically ill patients, and the pressure is at the end of the day a privilege, and I feel like we have one of the best jobs in the world. And this is me doing improv, and this is one of my, actually this was a team member in one of my classes at UCB. She was in her 80s, and everyone was shocked when she walked into the room, but she was amazing. So she was an actress. She is an actress. And these are some pictures from intern year and then second year. This was Women's Night. And this is Don before he was chief. And this is us at ASAP in Colorado. And then this is one of the post-in services, and this is the last post-in service, or last in service. We didn't, yeah. So. And then this was disaster day, intern year, and then realizing when we had our own disaster, I feel like, it made you really think like this residency program is the best one and in the US, because like we were prepared. And we didn't know, what was coming, but I feel like we were all really prepared. And this was my time on inpatient, the surge when I was called in April for 6 nights when I was on elective. I felt stressed at first going in, but this was night 6, and I was so amazed at how everyone came together. I had an NP from psychiatry on my team. I had a pediatric resident that was redeployed. She was an intern, and everyone was amazing. And I led the team that night, and I felt like everyone was just working together, and it was amazing. And this was in Dubai, so some good memories from residency. And then I went to Hawaii on an elective, which I really recommend everyone do. It was one of the best experiences, and I had never been to Hawaii in my life, so I was amazed. And then this is my hometown, Louisville, Kentucky. And then this is Brooklyn, where I moved 4 years ago. And then this is my family. I'm really thankful for them. It's my mom, my dad, my older siblings, and then my niece and nephew, and then my grandmother. And so I guess I'm still making the same face 30 years later. And thank you, Dr. Gernsheimer, Dr. Willis, Dr. Benson for reviewing my PowerPoint, and Dr. Sinnert for teaching me how to use mesh terms on PubMed, because I didn't know what mesh terms were, and also being a mentor as well. And then I also thank you, Dr. Reagan, Dr. Schechter for being my assistant program director and program director, and Dr. Willis for being program director. And if we have any time, just for any questions or any comments that anyone wants to make out in Zoom about anything we talked about. But thank you so much for joining.
That was really good. Thank you for doing this.
Okay, thank you guys.